Good afternoon, everybody. My name is Garrett Schmidt, and I'm the managing editor for BBC Exhibit Hall. And I'd like to welcome you all to today's webinar hosted by Topcon Screen. And it is titled How a Shared Care Program Can Save People's Vision While Improving ROI. And this is a really interesting a session. I've had a sneak preview of it, and so I'm really excited for you guys to be able to see this today. A few items of note before we get started. Now, all attendees have joined us today in listen-only mode, so you don't need to worry about muting your microphone or turning off your camera. That's already been done for you. And also, I'd like to let you know that the webinar is being recorded. So what's going to happen is after we're done, I'm going to send everybody that's registered, even if they're not in attendance, if they've registered, I'm going to send everyone a link to the recording and also where you can download the couple slides that we have from today's presentation. It'll be mostly in conversational form, so there won't be a ton of slides, but there'll be a couple that you'll want to have. And then finally, during the webinar, we want to hear from you. So a big part of this is going to be the Q&A that we do at the end. So we want to take audience questions. So at any time, you'll be able to ask questions through your attendee module. There's a little place where you can actually ask questions. It's not the chat, it's actually a little question module. And we're going to get to as many of those as we possibly can during the session today. If we can't get to yours, then we'll make sure to reach out via email afterwards to answer your questions. So again, we definitely want to hear from you. You don't have to wait till the Q&A to ask, so please do. And then finally, without further ado, I'd like to introduce very briefly our speakers. Mr. John Bartolovich, who's the Healthcare Economics and Reimbursement Manager with Topcon Screen.
Hello, everybody.
Welcome, John. Mr. Corey Chapman, who is the National Sales Director screening at Topcon Screen, and he's going to probably be doing a little of the moderation for us today. And then Dr. Wade Brocious, who's Medical Director of PMSI. And so glad to have you gentlemen with us today. And at this time, I'm going to hand it over to Corey. So welcome.
All right. Thanks, Garrett. Dr. Brocious, great to see you again. Thanks for spending some time this afternoon with us. So let's just get right into it. Yeah, so tell us a little bit about yourself.
So as you said, my name is Wade Brocious. I'm the medical director for PMSI, and I've been in this role on and off for about 15 years. I've been in practice for 28 years, and PMSI is in the northwestern suburbs of Philadelphia. Our company services about 180,000 primary care lives.
Okay, well, what do you find interesting or important about your field?
So I'm family medicine, and family medicine has changed a bit over the course of the years, right? So we went for from a volume model to a value model. So what's happened quickly is before was, hey, fee for service for the most part. You get people in the door, you give them the very best possible care you can, but a lot of times back then, there weren't necessarily quotas, but there were ideal goals of how many patients are seen. What's happened over the course of time is we've switched to a value-based care model, which really, quite honestly, is better for the patient, it's better for the provider. And what we look at now is not just only, hey, are we getting paid for the patients, but are we getting them to goal across their HEDIS stars measures? Also, many of the models are looking at medical cost ratios. So are you able to, not only help to improve the quality of care, but are you able to keep the global cost of care down?
And when you're looking at that, doctor, with your diabetic patient panel, what type of struggles or opportunities are you seeing as part of that treatment plan for them?
Well, until about 2.5 years ago, when there was a small little thing like a public health emergency, it was already a struggle because really you need to have access to care, right? You need to get your patients in the door to be able to make sure they get their adequate level of care so that you can improve their A1C and you can make sure all the tests are performed. And again, back then especially, it was trying to get access not just only to primary care providers, but to eye health care specialists as well, right? And then we have to try and make sure that in the realm of social determinants of health, that we're able to not only just get access to care, but can the patients financially afford the care? Do they have transportation to that care? And also, are they having the appropriate follow-up that they need?
So just as a follow-up, social determinants of health seem to be probably one of the bigger struggles for your patients.
It really is. It's one of the things we've built into our pre-visit planning tool, so that way we can make sure we ask every patient every visit, because you'd be surprised at how many people that you're assuming are totally fine, only to find out that they really are struggling to make ends meet day to day. Not just only that, but quite honestly, there's not immediate access to transportation like you would think there is. And so having the ability to perform Topcon screen in a primary care setting has really revolutionized the ability to actually improve the quality of care.
So specifically around diabetes care, how do the social determinants of health play a role?
Well, if you can't get the appointment, that's issue number one. If they can't get transportation, it's really hard for someone to get the eye care exam they need, because although in primary care, we still on occasion do home visits, it's not like ophthalmologists carry around their retinal machinery to the patient's home, right? So I think having the ability to have that screening access in the office, where truly at point of care, we've been able to dramatically improve our HEDIS stars measures in regards to closing that care gap. And again, it's interesting because if you look at HEDIS stars measures and value-based contracts, diabetes points make up more than half of all the points in the HEDIS stars measures that you're being compensated for. So this is a really big thing, is to get the patients in and then be able to give them the highest level of care they can possibly get, including their eye health exam.
So fair to say the retinopathy screening program plays an integral part in your practice?
Absolutely. And again, what we did is we built it into our pre-visit planning tool. So that way we really document very well, have they had their A1C, their lipid panel, their microalbumin to creatinine ratio. But the other big thing is, have they had their retinal screening done yet this calendar year? If the answer is no, even if it's later in the year, we make sure that we do it. Now, we try and do most of them in the first part of the year, but sometimes things slide through, whether there be emergencies or other things, but it's one of the things that's built in there, so it's not missed at any visit.
And you hinted at, or maybe not hinted at, this has had a positive impact on your HEDIS and stars?
Dramatically so. I'm lucky enough, I sit on a bunch of boards in the primary care arena in the Philadelphia marketplace, and I can tell you this is a real struggle for primary care, not just in our little tiny geography, but across the entire 5-county region, including the metropolitan region of Philadelphia. And this is one of the things that has allowed us to really be in the top quintile of all practices across the 5-county marketplace.
Oh, that's fantastic. So, Doctor, what exactly is a shared care program, and how does it help you to address the gaps in care with your diabetic patients?
So, as I'm sure you're probably aware, John, shared care really means that it's a patient-centric system, right, that allows everyone to have communication across the entire care team, meaning not just only their provider, but also specialists and the patient themselves, right? So in this particular case, what's allowing us to do is to have access to the patient while they're in our office and be able to offer them the opportunity to have their retinal screening done at point of care. We get reports back very quickly, generally 1 to 2 days. But what's awesome about it is, in that regard, once we get that report back, if the screen itself is abnormal, the recommendation is to send the patient then to the eye care specialist so they can have further evaluation. And what we do is we forward a copy of that screening report right to the eye care specialist so they're aware.
And this is, again, how has this implementation of the shared care impact not just the diabetic retinopathy, but all of your HEDIS concerns?
Well, it's really important. Sometimes there's downsides because whether people like it or not, there's communication difficulties between specialists and primary care. So we spend a fair amount of time tracking down things such as mammograms or colorectal screening results from colonoscopies, et cetera. But again, that sort of interconnectivity with the patient being at the center of that whole thing, being able to have a communication between primary care and specialists, and then communication back to the patient themselves, so that way we can make sure that the measure really is closed, is really, really important. And we, in our group, we actually have a feedback loop. So if we give an order and the patient doesn't complete it within a certain amount of time, we reach back out to the patient and say, well, why didn't you get, and fill in the blank. And sometimes it's access, sometimes it's money, sometimes it's just they need further education and encouragement.
And how did this impact chart chasing? I hate to say, did your staff get more free time, because we know there is no such thing as free time in a practice, but has it cut down on chart chasing?
Yeah, well, it certainly has. Being electronic, you'd like to think makes it a lot easier. It only makes it easier in the fact that you're not flipping pages inside of a paper chart, right? But nonetheless, you can actually quickly see inside the EMR whether or not the patient's had the screenings done. And if not, then the immediate outreach to the specialist or the radiology department or what have you is done. And you're right, it's really not free time, it's expensive time. We're paying our employees a decent amount of money to chase these reports. You can imagine in a primary care setting, when you're able to do something like Topcon screen and it's done at point of care and the report is sent to you really quickly, you're not chasing reports. It's already there.
And
So
when
how
it came,
has oh, sorry, John, go ahead.
I was just going to tag on that. And what factors did you consider when it came to ROI?
Well, again, in our group, what we try and do, and me as medical director, we look at things from the quadruple aim perspective, right? So are we improving quality? Are we decreasing costs? Are we improving patient satisfaction? Are we improving provider satisfaction, right? And if we can get at least 3 of the 4, and God willing, the ultimate is to get 4 of the 4, we're doing something good. So we decided to take this on as a project. The very first thing is, are we doing good for the patient? The answer is definitively yes, right? So that was simple. Are we able to make it so that it's easy and beneficial for the provider? Absolutely. The provider just has their medical assistant or office manager or someone take the patient back to the room to perform the exam. So that was easy. And then the question that you have is, well, is there some level of ROI that makes sense? That to me is a bonus on top of the quadruple aim, right? Because we're clearly decreasing global costs because the patients that don't need to go for an expensive consultation are saved from that, right? We're clearly able to improve value because we're able to save vision, which again has tremendous amounts of uphill costs if you let it go downstream too much, right? So we've done that. Then when it comes down to ROI, that's the cherry on top of everything, right? Because now what we're able to do is not only do all of those 4 things, but also make a couple bucks in the meantime, right? So it was important, but it wasn't the most important, right? I think, meeting the quadruple aim to me was the most important, and then being able to make some level of profitability on top, that's just fantastic.
All right, Dr. Brocious, so how has your workflow changed since implementing Topcon Screen?
Well, I had developed the pre-visit planning tool. That was problem number 1. And since then, what we were able to do is make sure that we have a team approach. There was just recently an article that's published that said that if all primary care doctors did what they need to do to meet all quality standards, good documentation, and make sure the patients get the care that they only need 27 hours a day. Truly, it was just published, right? So the thing is, what they were stressing is that, well, although not perfect, if you get a team approach, you can cut that down to 9 hours a day, right? So a lot of what's happened inside of our practices is that we've really developed a team approach to try and make sure this is done. And it's pretty simple because that pre-visit planning tool helps to allow our team have the access to the information they need. And everyone's aware that it's as simple as, have you had your retinal screen yet this year? Yes, okay. Is it in the chart? Okay, already done, no problem. Or no, now we have to reach out to the provider, which they do real time while the patient's in the office, just to make sure that the patient wasn't confused, and we can definitely get a report and confirmation they had it. If the answer is no, or they were confused and they still really just not go there, it's done then. And what we do really simply is, not that I'm proud of it, but I do run behind on occasion. And so what we try to do is, if I'm running behind, so the patient really doesn't get that perception that they're wasting their time in a waiting room, they'll take them back, they'll do the retinal screen first. They'll see me. If I'm running right on time, what happens is I'm in there, patient's in there, and then afterwards, immediately afterwards, before they check out, they get the retinal screen.
So how did this all start? How did you implement Topcon Screen? Well,
did a little bit of research. I think trying to figure out what's best for the patient is always a great place to start. You want to sort of lead your professional life and your personal life by the golden rule as much as possible. So what would I want if it were me, my wife, my dad, etc. So I did a fair amount of reading, and and looking, and thankfully things like Medical Economics and other journals sort of had some information on this already. And from that point, it came down to, okay, well, who's going to be the best company? And after doing a decent amount of research and speaking to a couple of companies, it became very clear to me that for PMSI, Topcon was the #1 choice.
Okay, so describe the learning curve for your staff in becoming proficient with Topcon Screen.
Sure. So the first thing we did at PMSI was we made the decision that we wanted to have buy-in from the practices, that this was something that was worth their time, worth the patient's time, and we worked a little bit through the billing to try and make sure that was going well. We started off with a handheld device. And we did that because we wanted to make sure that we were going to have the offices at least truly utilize the machinery appropriately. Once I got above 25 screens, we recognized that, hey, listen, yes, they're going to be doing this, and then we're going to switch over to the desktop model. We did that, and it was unbelievably seamless. Not to mention, I will tell you that switching over to the desktop model was the best thing that we've ever done. It improved the employee satisfaction, improved the patient satisfaction, and it's very, very quick. And quite honestly, almost foolproof. And even if you screw up, what's great about Topcon is we get a report back saying, hey, there was an error in the read, and here's how you can fix it moving forward if this continues to happen, right? So really, we've been able to be very successful with Topcon because of the support as well.
Can you tell us a story about a patient you were able to serve or serve better with Topcon Screen?
Yeah, I mean, there are so many to think about, but probably the one that comes to mind most was someone that was done not too long ago, and that was a patient that was sort of drug into our office kicking and screaming because, quite honestly, they were a little bit afraid to go out because of COVID-19. And so we tried to make sure that we were able to get the patient set up for med refills and blood draws and collection of the urine, et cetera. And one of the other things we asked, again, built into that screening tool was, hey, have you had your retinal screen? And they admitted that no, in fact, it's been almost 2 years since they last had their retinal screen done. And they said, well, would you mind if we just go ahead and do it while you're here? And quite honestly, they were amazed. And then they were further amazed that we called them back one day later to say, hey, we've already gotten the report back with the read from the eye care professional, and I'm happy to tell you that your screening was great, right? So it was very seamless, and it really alleviated the patient's fears because, quite honestly, they would have not gone to their eye care specialist just because they were that afraid of exposure.
So, Dr. Brocious, in your opinion, what's the future of shared care healthcare and/or telehealth, for that matter?
Yeah, well, this is one of those things where it's already, the barn door is already wide open. Telehealth is not going to be going away. I think that CMS has already made it clear that, at least in certain aspects of care, it's really dramatically improved the quality of care, right? So, for example, in the behavioral health arena, it has dramatically improved. The rate of no-shows has gone down tremendously. Patients feel much more at ease opening up about real issues. But in regards to global shared care, I think that this is one of those things where we're really having a coordinated team approach in a much more efficient manner, right? So I'll give you something that's non-eye care just as an example. So, we're supposed to do hepatitis screenings for people. And if they screen positive for hepatitis C, what was happening before is people were going to GI, waiting for that visit, spending extra money on the consultation. The GI doc would tell them they need additional lab tests. They'd go, be all worried, wait more, spend more money, and then finally have an answer, right? Now what happens is we order all the tests in advance to have that one visit to be a very meaningful visit. Likewise, it's the same here, right? We're able to offer the screenings so that way we can make sure that the patients that are going to the eye care specialist have all the information that they need, right? So they already know that they were screened positive, that there are real concerns for these patients, and that we can then in turn make sure that the eye care specialists give the patient the highest level of care that they can with the information they have in front of them.
What has surprised you most or made you the happiest about joining the Topcon Screen family?
Wow, a lot, quite honestly. So I'll try and be brief. But number one is the ease of use, right? It's unbelievably easy to use, and as such, the patients enjoy having a lot of free time back in their day, right? As opposed to driving to an eye care specialist, sitting in the waiting room for the better part of an hour, and going through all the other things and giving up a couple hours. Two is the high quality of imaging that's done. We get the pictures back. If we want to, we can click onto our portal and we can see how good of a picture it is. Three is how responsive Topcon has been to not only getting us reports, but in the event that we start to have a problem or have a new hire and need additional training to have the screenings done the right way, it's been great. And not only that, I have a member of Topcon that I meet with every couple of weeks that we go over our numbers to try and make sure that we're having appropriate utilization, and we find out where the pain points are. So if there are some offices that are not as vigorous about their screening, we try and figure out, well, why? Is it a staffing issue? Are they having problems with the machinery? Is there a problem where the patients are giving a little bit of reluctancy or what? And we've been able to work through those simple problems all with a few conversations.
Great. Now, if you could make the case for Topcon Screen to viewers, I was going to say in one sentence, but take as much time as you want. What would you tell them?
Well, not to steal from Nike, but just do it. I will tell you that you will not be really disappointed. Again, having the ability to improve the quality of care at the point of care and improve patient satisfaction cannot be understated. What it does to your bottom line is also helpful. Listen, you're not probably going to get rich $25 at a time, right? But I think that it's not just the $25 you're getting on the retinal screen, it's also dramatically improving your HEDIS stars measures, and in value-based contracts, that's where some bigger bucks will flow, right? So you can feel really good going to bed at night knowing that you've improved the quality of care for your patient, that you've helped your organization, and that potentially you've saved someone's vision.
Fantastic. Well, thank you, Dr. Brocious. We do appreciate you taking the time to join us today. Let's turn it back over to Garrett for our Q&A session.
All right, guys. Well, yeah, no, this was a fascinating conversation. I think it's something that's really important as well, obviously. And to reemphasize what one of you guys had said, yeah, just do it. To go and for your patients and for yourself, even, to check that out. We did have a few questions that came in that I want to go through in no particular order here. And if you do have a question for any of the speakers, go ahead and submit that now, and we'll get to, again, as many of those as we possibly can. So starting again in no particular order here, you talked about implementation a bit. How long did it actually take to be up and running?
Well, it was really quick. I will tell you that, first of all, Topcon does a great job. They offered the opportunity to have both virtual as well as in-person training. We took them up on both of those, quite honestly, because of new hires and what's been happening with the work staff over the course of the recent couple of years with COVID, the great retirement, et cetera. I will tell you that it did not take long after the training. Truly, we tried to start up within the course of a week of getting people screened in the office. Again, I will tell you that, the handheld, albeit not horrible, not nearly as easy as the desktop, because again, it's user dependent, right? And to a certain degree, it's patient dependent as well. You really need to make sure you have the dark room with a handheld, and you need to make sure that you have a proper angle. With the desktop, honestly, it's almost foolproof, right? So I will tell you that we were up and running within the course of a week as far as being able to get the scans done. So I would say it's pretty quick.
Great. Next question is, could you talk a little bit more about training? And is it done in person, online? How does that work?
Yeah, so like I said, it can be done both in person and virtually. Like I said, we did both, but I think the ability to have if you can do it in person, it's always a little bit better, right? Because it's hands-on. You can make sure that you truly are getting the chin inside the cup. You're trying to make the forehead up against the bar. And if there's any problems, you learn about it firsthand right there, real time. So that way you can make sure that moving forward while you're doing your patients, that there's not a problem. Because the good news for us is that the folks in the offices were screening themselves, if you will, on the practice round. And then you got to take a look at the pictures and you can see, hey, listen, oh, well, I did this wrong, or I know I did this perfect, so I know how to do it in the future.
Yeah, interesting. Okay, next question is, you talked about ROI. How difficult was it for you and your staff to deal with reimbursements? I know this is a burning question for me.
All right, so not hard, but what we did really is 2 steps, right? Number one is we contacted our billing company. We made sure that we had the appropriate codes to them and they confirmed for us that yes, these are appropriate codes for primary care screening. The second thing we did is we tried to run all of that by every one of our carriers, because it makes it really difficult to remember, hey, you can do it with this company, but not with this company. I'm happy to say that the overwhelming majority, in fact, actually with only one exception, we were getting reimbursed. So it made it pretty darn easy. And we did that up front before we even went live.
That's great. Okay, next question.
I was just going to say, if I might add to that, my team is always there to help clients like PMSI pre and post sale when it comes to reimbursement questions, concerns. So we work as a team to help make sure that that's covered adequately.
Great. And let me know if any of these are repetitive, because I'm just kind of clicking through them here because we got a lot that came in. Next question is your vision screening device FDA approved and reimbursed by Medicare? And how much money is reimbursed per visit? And again, you may have already answered this one.
So yes, and it depends. So what happens is regarding the reimbursement, most companies, so Medicare Advantage plans, Medicare, et cetera, there is a straight fee schedule. However, there is some small variances, especially on Medicare Advantage. Also, remember that there is a fee out to the eye care professional that's doing the reading. However, that fee is reduced by increasing amounts of volume. So last year, right off the bat, truly on first year, we did more than 1,000. So we were able to take about $5 off the total read of each retinal scan. And also they also allowed us to, if we wanted to discuss with our local community-based eye care professionals and negotiate our own rates. So you would have the opportunity to do that if you so desire.
Great.
And I would just again add to that rate is going to vary from state to state, and actually even from locality to locality within the state. But CMS coverage has been very, very good.
That's true, John. In our local area, we're lucky enough that we actually all of our sites fall in the metropolitan Philadelphia area, which is just a slight bump up compared to outside of the Philadelphia metropolitan area.
Exactly.
Great. Next question is, what optical diseases are detected by an ophthalmologist doing a retinal screen versus the desktop model used by your staff?
Well, listen, certainly there's no doubt that having a full dilated exam is a better screen, right? I mean, the reality is that if in fact there's abnormalities on the retinal screen in the office, the very first recommendation is, well, don't just assume this is fine. No, refer out to your local eye care specialist to begin with, right? So the one thing I can tell you though is we have gotten reports that it's not only finding evidence of specific diabetic retinal disease, but they've actually given us some recommendations for people who have had hypertensive eye disease and other things, right? Because again, they're taking a look at the retinal picture. So yes, they're able to see things, and unless it's a normal exam, the recommendation is, hey, there's abnormalities, please refer the patient to their eye care specialist.
Yeah, that's great. That's great advice.
Yeah, I was just going to add that our reading center is able to detect up to 30 different pathologies, ranging from AMD to glaucoma suspect, increased cup to disc, things of that nature. From a reimbursement standpoint, though, only diabetic retinopathy is reimbursed. And again, just touching on the reimbursement, as Dr. Brocious alluded to earlier, fee for service is, you're not going to get rich on that. Your real financial impact comes on the tail end with your HEDIS, your STARS, your risk adjustments.
Yeah, and I would think to add to that, I mean, just looking out for your patient population, because there's a lot of the body is a full system, and I'm sure there's we're caring for these individuals as human beings, and so looking out for their general health and their vision health is important as well. So next question is, what is your experience or success in venturing into home-based care?
So at PMSI, we have a lot of separate entities in the big picture of what we do. We do some level of home-based care. We also do chronic care management. We also do remote patient monitoring. We also have the opportunity, recently we'll be starting up an imaging division specific to try and help the load of mammography, because right now the wait time in our local geography is about 3 months for screenings. So not just only home-based care, I think, but multiple other aspects fall under the umbrella of what primary care is doing. And again, that talks back to the point of, hey, well, this is really all shared care model, right? We're trying to make sure that we're able to deliver all these services where necessary, right? So again, you don't want to just enroll everybody just because you're trying to make a buck. It's really like, okay, well, for example, for chronic care management or remote patient monitoring, if the patients had hospitalization and rehospitalization because of CHF, that makes sense, right? And so I think that retinal screening is one of those other things that we talked about is a perfect example of where the shared care model really comes into play.
Great. This next question is begins by saying this might be a crazy question, but I don't think it is a crazy question. It says, can a tech or another trained professional do the test, or does it have to be done by the physician who completes this exam?
Well, usually when you start off like that, it is a crazy question, but this one is not, right? So this is actually, again, one of those examples where we're talking specifically that it really takes a village to have an appropriate run medical office of any type right now, right? I'm happy to say that no, the physician is not performing the test. Quite honestly, in our office, we have either office managers or medical assistants that do it. I know some offices where they have LPNs or even RNs doing it, but I think the training is so good and the difficulty getting the image is so low that everyone should be operating to the highest scope of their license, right? In our offices, the reason that that the office managers can do it is almost all of them have been some type of healthcare professional that's worked their way up through the ranks to be medical office managers. But yes, I do not know of one office in our entire group where it's the physician that's actually doing the test.
No, that's really helpful. Very good. Yeah, not a crazy question. Next question is, you may or may not know this off the top of your head, but what CPT codes are you using in CPT2 code?
So I don't know it off the top of my head, but I'll leave that to John and or Corey because I'm 100% positive they know.
Yes, typically our clients tell us 92250 for the CPT code. Some plans do ask for 92228, and I'm happy to have a live discussion with whoever is interested in that to go over that. CPT2 codes, there are 7 different ones. Any of them can be utilized, but again, it's something we can discuss in a live conversation. The real key with the billing portion of this is you need 3 things. You need a CPT code, a CPT2 code, and an ICD-10 that demonstrates that the patient is a diabetic. And that is key because without that, no plan is going to cover it.
Was I the only one that saw John's face light up when you said CPT codes? He was ready to go, Dr.
He was ready.
Absolutely.
Very good. And the same individual actually asked this next question. Can you expand on your ROI, how you were making money on this? And you mentioned the $25 per screen and where you were getting that from. And I know you probably covered these at different times, but if you want to kind of reemphasize that.
Well, basically the bottom line is we have a reimbursement rate minus the fee that we pay to the eye care professional, and the yield is about $25 this year once we got over the 1,000 marker for screens done per calendar year. John, if you want to touch base, but again, the reimbursement is different in each state and each locale, so the economics will be just a little bit different depending on where you're calling from.
And again, this is one of those things where when I work with providers in their offices, one of the things I typically ask for is what their payer mix is, because then that allows me to start to develop a pro forma to help them understand what their reimbursement levels are going to be. And the providers and offices that really partner with us will get into discussions about what their value-based contract situation looks like, what their compliance rate look like, what it takes for them to get to achieving their bonus, say for a HEDIS on the eye exam for diabetics. And the more information that the office is willing to share with us, the better and more accurate picture financially we can paint for them. But again, that's part of the service Topcon will provide.
One of the things we did when we looked up how, just sort of a starting point, is we went to Novitas. Novitas, you can easily access their website. You can type in the codes. It'll tell you what it is for your local geography. So at least that's a jumping off point to try and get a handle on what's going on.
Exactly.
Okay, moving right along here. Next question is, what's an average financial impact on the back end Topcon Screen provides from achieving HEDIS?
I'd like to tell you, I can give you a direct answer, but remember that it's solely based on what your contract is, right? So unfortunately, so PMSI participates in 14 value-based contracts, including our ACO, and it's not a straight answer for any of them. They all have just a small tweak on what they value. But I can tell you that in regards to total points in value-based contracting, things such as medication adherence for diabetes or statin use for diabetes or heart disease are triple weighted measures. The retinal screen is generally 1 point for almost every company. So, it has to be part of your overall global diabetic management plan, right? So when we developed our pre-visit planning tool, what we try to do is we try to make sure that we hit every single one of those aspects, because quite honestly, more times than not, you're paid based on your sort of average for HEDIS stars quality measures, and even missing as little as 1 point could be detrimental to your overall score and therefore your finances.
And again, it's all dependent on your individual contracts, but I do remember reading, I think it was the Kaiser Family Foundation, that said, one HEDIS measure can be worth 6 figures to a practice. But again, that's all going to depend on what your bonuses are and what the contract reads.
And even your patient volume, right? So depending on how many people are enrolled in your Medicare Advantage organization or straight Medicare and ACOs, et cetera, all those things play a factor in the total number at the end.
Right, 100 patients in value-based contract obviously is not going to be worth as much as 1,000 patients in a value-based contract.
Mm-hmm. Great. Next question is actually more of a statement, and it's a little bit lengthy, so I'll paraphrase here. It says, we have Topcon, have had it for about a year, and we don't have a super high volume. We use the desktop model. It works great, multi-specialty group, and our endocrinology providers love it. Very easy to use. She mentions some different challenges they've had at different times with support, but says this has helped us absolutely immensely with our quality metrics. So great to hear feedback like that.
Absolutely. And again, I promise the listeners that if they just do it as well, they'll have that same type of response. It is very easy to implement. It is very easy to check off the quality measure. And most importantly, don't forget that this is really all about appropriate care of the patient and delivering the highest level of quality care for the patient. So, think about how great you feel if you just saved one person from needing needles in their eye, right?
Mm-hmm. Yeah, very good. Yeah, thank you for that comment.
Yeah, I think there's historical data out there shows that 1 in 10 diabetics is currently at some level of sight-threatening disease pathology right now. And when you look at the figures, 50% of those are going undetected because nationally we're at roughly a 50% compliance rate.
Wow. Next question is the exam something that you've marketed to patients in a specific way, or like did you outreach to a specific population to make appointments for the exam, or is it just an added benefit during an annual physical?
Wow, that's a loaded question just because of how it was worded. So we don't only do these at annual wellness visits, right, or comprehensive physical exams. It's done truly at the very first visit of the calendar year for most folks.
Okay.
Do we market it? No, but they are aware of the fact that we do have the machine. You'd be surprised at how quickly word of mouth, gets around town when people are getting service, and especially a high level quality of service where they feel that they're really being cared for the best way that they can. In regards to, are we trying to market it? It's not just that, because quite honestly, again, we built it into our pre-visit planning tool so that if someone is diabetic, that we ask that same type of question every single time, right?
Mhm.
So it's not like there's something hard about it. When we developed the pre-visit planning tool, we try to sort of make it where it's fully comprehensive, that independent of which carrier it is, that we're sort of collecting all the information for all those measures. And in my mind, it was easy. Why? Because the HEDIS stars measures are set up because it really is evidence-based. And the question is, well, just because one company decided to do one and not the other, and the second one picked B and not A, should we just say we're only going to be delivering these quality standards across to, based on the care? And our thought was, no, we really should be asking all these stuff of the same people, every person that comes through the door. So it wasn't specifically marketed, but I think it's something that's done universally. It was an easy workflow to implement.
It sounds like you treat this almost like a vital sign when the diabetic patient comes in.
It really is. And again, it's the same. So in the pre-visit planning tool, John, what we do is we try and put all the quality measures. So whether it be immunizations or cancer screenings, and other things that aren't necessarily sent for, but we do fall risk screenings and we do depression screenings and all these other things, all built into that same tool. But yeah, this is something that's done for every diabetic patient every year.
That's great. Next question is, what is your ACO quality score on retinal exam and diabetes management?
So thankfully, one of the things we don't have to have is we don't have to have that selected for a quality measure for our ACO. So I'd be lying if I can give you that. Quite honestly, our ACO is focusing on hypertension as their quality measure. So, but I can tell you that we are in sort of the 80 to 85th percentile, depending on which carrier we're at, for our measures for our Medicare Advantage organizations.
Wonderful. And then the last question here is, have you seen an uptick in activity or diagnosis since and during the pandemic?
So an uptick in what type of diagnosis? I just want to make sure I'm accurate on this, Garrett.
Yes. So I guess to clarify, that would be what maybe effect, or to rephrase the question, what effect has the pandemic had on outcomes?
Well, a couple of things. I mean, number one is, we rapidly transitioned from in-person visits to telehealth visits within the course of 1 to 2 weeks. So it was relatively quick for an organization our side. And we did it by simply there's like a list of 22 chronic conditions that we were able to sort of pull out and say, well, who hasn't been here within the course of the past 3 to 6 months? Let's have outreach. I can tell you that globally, if you take a look, you'll see that there has been a dramatic reduction in incidence of appropriate screenings, right? So unfortunately, there has been an uptick in diagnoses of things such as cancers, colorectal cancer, breast cancer, et cetera, because those screenings were not done during that time. I think that's a real shame. And again, the good news is that once we were able to get people back into the office comfortably, and for those that were happy to come in to begin with, it was business as usual for us as far as doing our retinal screenings, right? Because it's very easy to quickly clean up the machine and make sure things are good, and you're not going to be worried about transmission of infection from one person to another. So hopefully that answers that question, because again, it's a little bit of an interesting question, but I think in particular, if you're talking about screenings and therefore increasing amounts of disease states, it's pretty well documented that because of the reduction in screenings that were being performed, there has been an uptick in more significant pathology.
Very interesting. Very interesting. Well, everybody, unfortunately, that is all the time that we have for questions today, and we're going to go ahead and wrap this one up. But as we conclude, I wanted to encourage you all to visit the Topcon Healthcare booth, the virtual booth at VBC Exhibit Hall. And this is a place where you can connect with the team and learn a lot more about what they're doing and some of their some of the activities they're involved in. And so definitely want to encourage you to go visit that. Again, bbcexhibithall.com. It's also where you'll be able to find a recording of this session in our library. We have all of our webinars archived there. So please head over and take a look. And then lastly, I just wanted to thank again our speakers today. I really appreciate this conversation. And I know I learned a lot, and so I hope you guys did as well. And if you would like to reach out to any of them or to anyone on the Topcon Healthcare team, please reach out to either John or Corey. Their information is here on this final slide, or you can reach out to me and I'm happy to facilitate an introduction. But thank you all for coming. Appreciate you spending your afternoon with us. Hope you have a wonderful rest of your day. Thank you.
Thanks, everybody.
Thank you, everybody.